This is part 3 of the complete hemodialysis video series. In the last video, we have left it in the midway of AV fistula. So we'll continue the discussion from there. So this video will be revolving around sites for atriovenous fistula. A common question might arise, since the blood supply have to be at a higher pressure to supply it to the dialyzer, why not we directly take it from artery? The demerits of taking it from artery are there is a high chances of arterial damage. The distant area which the artery supplies might go for ischemia. Second, artery are usually deep, very difficult to cannulate. Third, the size of the artery is small. The AV cannulation, the atriovenous fistula cannulation needle can't be inserted properly. The vessel remodeling won't be there. So these are all the reason why the artery is not being used directly to take the blood out and to supply to the dialyzer. So that is why we need the AV fistula. What are all the sites the AV fistula can be made? To know this, you should know the vessel anatomy of the upper limb. Just look at this important vein, which is the cephalic vein. On the lateral side of the forearm, goes on the lateral side of the arm and joins the basilic vein and forms the axillary vein. Another important vein is the basilic vein, which is on the medial side of the hand. These are all the two important veins. Long, length is also significantly more. Caliber is also big. And when you look at the artery, as you know, the radial artery on the lateral side, ulnar artery on the medial side. These are all the branches of the brachial artery. So this is the most important vessel anatomy you have to be aware to decide on the areas where atriovenous fistula can be made. Ideally, non-dominant hand of the patient to be preferred so that heavy weight lifting can be avoided. In the AV fistula creation, there are two types of fistula considering the site. One is conventional, another one is transpositional fistula. Simple. Conventional means there is no much mobilization. Wherever the anatomy is, just you are making the connection. Transposition means you are taking the vein, dissecting it and putting it in some other area is called transpositional. These two terminology students might get confused. It is nothing but we are not altering the much of the anatomy, just connecting as it is. That is why I kept the two diagram to know the vessel anatomy. Transposition means the vessel is being dissected and some part of it being taken from one part and kept in the another part. That is transposition. So where are all the areas the fistula can be made? The conventional one. See, the radial artery is here. The cephalic, the big vein is also here. So here you can make the wrist, most common site of AV fistula. The radial artery connected to the cephalic vein, which is called as the radiocephalic fistula. In the most distant part, if the vein is good, here also in the wrist area, anatomical snuff box can also be made, the conventional AV fistula. That two vessel, if it is good, that can be connected. What is the minimum size the vein should be? It should be in the Doppler, should be minimum 2 mm, so that the vein and artery can be connected without much difficulty. The second most common area is here we are having cephalic vein and the brachial artery. Here also you can make the conventional AV fistula. And the brachial artery and the basilic vein, the third side. These are all the three most commonly used site for the AV fistula. Here we will say as brachiocephalic fistula. Here it will say as brachiobasilic fistula. But what is the problem with brachiobasilic fistula is, look at the vein here, it goes very medially, difficult to cannulate it. The dialysis technician or who are cannulating it, they will have so much difficulty. So some kind of dissection might be required. What is dissection? Dissection is nothing but we are dissecting this vein and putting it more medially and connecting it to the artery. So this might encounter the transposition procedure. Many a conventional fistula can be made on a single setting within maximum 1 to 2 hours. It can be made here radiocephalic, here brachiocephalic, here brachiobasilic. Which is the most commonly preferred is radiocephalic, second brachiocephalic, brachiobasilic. It might require transposition. Transposition means we are changing the position of the vein from its natural area to a dissecting and putting in the another area. It might require a two-step surgery. First time, the vein might have to be mobilized after a period of 2 to 3 days. Probably another kind, and one more sitting of surgery might be required. So the transposition surgeries might be at 2 sitting or 1 sitting, depend on the patient vessel anatomy. So where are all the other areas fistula can be made? These three the commonly used areas though I told. Look at the anatomy. For example, in the forearm also, cephalic vein and the radial artery are nearby. In the forearm also it can be made, the conventional one. Suppose for some patient if cephalic vein is not good, you can try to connect with the basilic vein. Look at the basilic vein is here, radial artery is here. You can try to connect it by dissection and all. If cephalic vein, basilic vein are not there, if the perforator veins, this not prominent veins are prominent, if in a particular patient, if it is prominent, that can also be connected. So in summary, where are all the sites it can be made? One is in the anatomical snuff box, radial artery and the cephalic vein. Second in the wrist, which is called as fistula, which I discussed in the video number 2 of the AV fistula series. Third, brachial artery cephalic vein, which is the brachiocephalic fistula. Fourth, brachiobasilic fistula. These are all the most commonly clinically encountered anatomical sites of AV fistula. And what is the advantage of being making the fistula at the distal site is the proximal. Suppose if it is failed or if it is thrombosed, the proximal site can be used for making the another fistula. Suppose if right away this fistula is made, the entire this segment will be wasted. It can't be used because this area will be damaged, so this can't be used. So these are all the common site. Fourth we have seen the blue circled one. For MCQ point of view, what are the other areas? One is the forearm radial artery and the cephalic vein, brachial vein and the radial artery, perforator vein and the ulnar artery. Whenever the artery and the vein is prominent, the cutoff, as I told, in the distal it should be 2. In the proximal area, the vein and the artery side diameter should be minimum 2.5 mm. So these are all the sites in the upper limb. The advantage of making the fistula at the distal part of the hand, as I told, if this area getting thrombosed, the proximal in the forearm or in the arm, the next fistula can be made. This can be successful. That is why always try to make the fistula at the distant portion, the distal wrist, which is the preferred site. And to complete the discussion of sites of AV fistula, we have discussed regarding the upper limb fistula. What about the other area? Suppose if the patient, all the veins in the upper limbs are damaged or thrombosed, is it possible to make in the lower limb? Yes, theoretically they have tried with the great saphenous vein and the superficial femoral artery, popliteal artery and the saphenous vein for the theoretical discussion, but practically it has lot of disadvantage. And in my experience of 5 years plus in nephrology, I have never seen a lower limb fistula, and even my seniors also never told regarding the lower limb fistula. But in theory textbook, they have written what are the disadvantage. The flow will be very high. Patient might go for the cardiac failure, high chances of lower limb ischemia. The longevity is very poor. That's why they won't prefer, because Why we are making fistula in the upper limb? Because of the longevity. For a long period of time, over years, the fistula will be functioning. Suppose if it is made in the lower limb, the longevity is not there. So if someone asks whether fistula can be moved in the lower limb, the answer is yes, it can be made, but it is associated with a lot of complications. That's all. So in summary, in the upper limb, 3 site most commonly radiocephalic, followed by brachiocephalic, followed by brachiobasilic fistula. Other non-prominent site in the forearm with the artery and the ulnar basilic vein, the sites I have discussed. Two types. Conventional means the anatomy is not much altered. Transposition means anatomy is altered. The vein being dissected and kept in another place. So these are regarding the sites of AV fistula. So this video will be to be continued as it is crossing 10 minutes already. So we'll see in the part 4 to be continued. Bye bye.